Okay, okay. So again, nice setup, nice live. Congratulations to Abed and Nawaf and everybody for arranging it so well. I am in a patient who is 75-year-old young lady. She has a large flat lesion in the cecum, and I'm under the supervision of Ahmad, so he is there to supervise me and see I'm doing it well. And if I do any mistakes, he will take over from me. So, Ahmad, what do you think of the lesion?
Yeah, so hi everybody, and thanks again to everybody for having us involved. We have a lesion here in the right colon in the cecum, which you guys can appreciate. It seems like it's a Paris Class 1S in appearance with a JNET 2A overall appearance as well. We are using the Olympus system here. We have a colonoscope with the X1 module. We are using MBI, which you guys can see here is giving us very beautiful visibility and the characteristics of the polyp itself. This polyp is in the cecum. It's quite close, but thankfully not abutting or involving the AO, which Dr. Yogesh will show you here in a second, right there.
So this is the appendix.
The appendiceal orifice
away,
right there.
Away from it.
And you guys can see here that this lesion, you have numerous options that Dr. Yogesh and I were speaking about. There's different ways of approaching this.
The beauty of this scope is you can magnify, and you can go up to 1.6 times magnification, and of course the NBI with magnification can really help us define. So this is like a Genet type 2A, you know, on magnification and on NBI. So as Ahmed was saying, there are various options to go about. So we discussed, one is underwater.
Correct,
What do you say?
I think underwater is definitely an option here. We were a little bit concerned about the size of the polyp. There's some component where we feel we may not be able to grab it all en bloc. And so we discussed obviously a lift and classical snare polypectomy with heat. Or, you know, we were discussing, thankfully both of us are on the same side of the pendulum that's swinging, in that cold snare piecemeal is a very good option here. It'll give you a safe resection, and you know that the risk of injury is quite low.
And we are on the right colon, and she is 75-year-old lady. And another thing, it's a Genet type 2A, so the chances of it having, we are not able, or it's advanced, advanced polyp is very, very less. So I think it's safer to inject and start.
Yeah.
So I think we'll inject.
We'll go ahead and start. So we have a mixture here of saline with methylene blue, and we added just 1 cc of 1 to 1,000 of epinephrine in hopes that that would reduce the risk of bleeding. That may make you know, the resection a bit more difficult. We're using a
and another thing we missed on that there's AI. This is a CAT system, so it picks up I think you can see the PIP, and also you can see it here. So it helps us to pick up the lesion. So that's another feature of this scope. And of course, other than that, you have other modalities like you can do TXI, you can have the RDI and all those features which will help us to, we can use it if there's a bleeding or something like that.
So we were just discussing the positioning of the patient. We're a bit cognizant that you know, the risk of bleeding is still there, and we are in the gravity-dependent portion. So we did move the patient a bit so that the pool of fluid is really not obscuring us.
But it's in the base of the cecum, so it's not really very easy to get it out of the gravity. So needle out.
Say that one more time. You said underwater.
Inject. Start inject.
Yeah. Yes, you know, I think our biggest concern why we didn't use en bloc is why we didn't use underwater is a concern that maybe we might not be able to get it all en bloc. But I do think it's a great option if you can get it. And as you can see here, the lift changes a lot. You have islands of tissue that are interspersed with probably normal mucosa. And this obviously makes an en bloc resection a little bit harder because, you know, I think the snare struggles to grasp everything.
We could have used a 20 mm, that's it, stop, 20 mm snare, but I'm a little bit concerned about.
One more minute, okay?
Okay, out.
So we're going to continue to lift here and start our process soon.
Inject.
We're going to use a snare master here that's 15 millimeters.
Stop.
We
Yeah,
always recommend
I
using
think
a
this looks
sharp
okay,
snare
right?
to resect.
I
It looks
think
great.
just little bit here. So that's what he was mentioning, you know, if it starts bleeding, sometimes it's difficult. Needle out, please. Inject. I think that should be enough. Thank you. Stop. 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 Needle out. So as you can see, we have elevated the lesion, and we'll try to grab it piecemeal and resect
We'll
it.
get the snare ready, please.
Snare, please. So there are various ways of injection, Dr. Ahmed. So a lot of people, they ask the assistant to start injecting before puncturing, so that you go into the submucosal plane and you get a good lift, because sometimes there could be the lesion, the injection which could be superficial, and it will form a bleb and it will hinder your resection. Out.
So they moved.
Yeah. Can you hear,
Alright.
guys? So we are finding some part which was not very well lifting. So we have done partly the job. Can I give me the snare, please? So as you can see, this is
Let's
a
try
very
this one,
clean
please,
margin. We have cut it here. This is the spongy submucosa, which is very well highlighted by the methylene blue. So I use methylene blue. Do you use something else? Or
Yeah,
lot
you know,
of
my
people-
combo was previously Hedestarch or Hespan, which I find it a bit more heavier with some methylene blue and epinephrine. But I'll sometimes also use saline interchangeably.
I also use starch, but that's mainly for ESDs, because you need a lift for a little bit
Correct.
longer. But for these lesions, as you can see, the gravity is hampering our work, because we tried to change the position, but it's not changing in any way. So we are not finding very good. Open.
Yeah, we struggled a bit with the lift here. But I think we're almost there. We have a 10 millimeter snare here, which we're hoping we can get most of this. This is probably one of those
Close,
lesions where after I resect, I'll probably also, coagulate the margins just to really
Cut.
reduce that risk of recurrence. So I'll use either a snare tip or a biopsy forcep or APC, and I'll just march around the lesion because I really want that risk of recurrence to go as low as possible. So as you guys can see, we're just kind of moving away from the center of the lesion towards the periphery, and we're
Another thing, Ahmed, very important, is you should not leave any islands in
Yes.
between, because that puts the patient at the risk. Open, please.
and you guys can see how the epinephrine helps here.
Close. So as I said earlier, we have to be very careful that you don't leave anything, any islands in between. So you have to have a cover every area. So I think we are almost done. There is this small piece which is there. Out.
So you guys can see how helpful here the Olympus
Open
scope is in showing us where tissue is, where resected area is, and where
Close.
you can even use MBI halfway through if you're not sure about what you're looking at, especially when it comes to this point where you worry
Another
about
thing,
islands.
Ahmed, what do you think of coagulating the edges, like snare tip coagulation?
Yes.
Because that has also been shown to reduce the risk of recurrences, because it has been shown that in cold snare, that is another
Absolutely.
big
Absolutely. I think, like I said, I would definitely employ that here. The nice thing is the Olympus generator gives you that ability to
Close.
zap the edges
Close.
to reduce the risk.
Close. Not really, because we can see the submucosa very well. There are no vessels, and we have not used any heat. The problem happens when you use heat. There is risk of delayed bleeding. With cold snare, the good point is you will have bleeding at that time, but delayed bleeding is almost nil. And even the perforation risk is extremely low. There are